Acute pancreatitis is a non-bacterial inflammation of pancreas caused due to activation of pancreatic enzymes leading on to autodigestion of pancreas, which presents with acute abdominal pain. It can be the first attack of the patient, or it can be the relapse follow, following the normal period where the patient doesn't have any symptoms. So, to talk about the etiopathophysiology of this condition, acute pancreatitis, what is the etiology? How can pancreas get inflamed? The pancreas inflammation can occur because of pancreas injury or due to obstruction of the duct. How does pancreatic injury occur, or how does duct obstruction occur? The most common cause of pancreatitis in our country is alcohol intake. The alcohol intake causes increase in secretions, that is, the gastric and pancreatic secretions, which are protein rich. These secretions can go and plug the duct, pancreatic duct. Due to plugging of the pancreatic duct, there will be obstruction, and also the alcohol will cause spasm of sphincter of Oddi. This will cause obstruction of the duct. So in 40 to 50% of patients, the pancreatitis is due to alcohol intake. In 20 to 30% of patients, the pancreatitis is secondary to obstruction of pancreatic duct due to gallstones. Then we have some conditions which cause obstruction of the opening, that is sphincter of Oddi obstruction. It may be due to periampullary carcinoma or due to duodenal ulcer. So also the duct can get disrupted and the enzymes can extravasate due to trauma, which causes edema, like after sphincterotomy or cannulation of common bile duct or basketing of stones. These surgical procedures can cause edema in the duct due to trauma. So it will cause the duct obstruction, and the patient can have attack of acute pancreatitis. Along with duct obstruction, some conditions will cause premature activation of enzymes. More commonly, those are hyperparathyroidism, causing increase in calcium levels. This hypercalcemia increases the pancreatic secretions, which similar to alcohol will plug the duct. Along with that, it causes premature activation of trypsinogen to trypsin, thereby causing pancreatitis. If the patient has hyperlipidemia, it leads to the conversion of the lipids to the free fatty acids by pancreatic lipase. The lipids, those are the triglycerides, which are increased in the blood and in the pancreatic tissue, will be converted to free fatty acids, which have toxic effects to the pancreas. Also, this can secondarily activate other enzymes. Then we have certain conditions which cause pancreatic injury, which lead on to pancreatitis. We saw duct obstruction, secondary to alcohol intake, gallstones, duodenal ulcer, carcinoma, hyperparathyroidism, hyperlipidemia. Also some surgical procedures. Then we are seeing the etiologies which directly injure the pancreas. Those are the things which cause ischemia in the pancreas, like hypotension, which can be secondary to any of the conditions leading to shock, or scorpion sting. This causes ischemia to the pancreatic tissue and thereby causing pancreatic inflammation. Then we have autoimmune attack in case of polyarteritis nodosa, the autoimmune disease. These antibodies are produced against the pancreatic tissue, which will damage the pancreas. We have infection with Coxsackie virus and mumps. These viruses, they are acini cell trophic, meaning they directly attack the acini of the pancreas, thereby causing injury. Along with that, they induce production of autoantibodies against the pancreatic tissue, thereby causing damage to the pancreas and pancreatitis. These are all the etiologies which lead on to, which ultimately lead on to autodigestion. What am I talking? Autodigestion meaning the pancreatic enzymes, the exocrine and endocrine pancreatic enzymes are produced. The exocrine secretions like trypsinogen, chymotrypsinogen, and other enzymes. These enzymes are produced in order to digest the food that we consume. Those are not produced to digest pancreas. But if they are activated inside the pancreas, when the normal physiological mechanisms which are in play to protect the pancreas from these secretions are impaired, leading on to premature activation of these enzymes inside the pancreas, it leads to auto-digestion of pancreas, meaning that the enzymes secreted by pancreas will attack against the pancreas itself. Now, some postulated theories are obstruction disorder due to many causes. Due to stasis of the pancreatic secretions, it can get activated, the enzymes. Then we have duodenal reflex, one of the theories saying, meaning the pancreatic enzymes which are activated in the duodenum by enterokinase, that trypsinogen is converted to trypsin, and trypsin converts all the proenzymes formed to the active forms. This can get reflux back into the pancreatic duct, causing autodigestion. This is one of the theory. And also we have another theory which says that the back diffusion is responsible for autodigestion. There is premature activation of trypsinogen to trypsin. What is back diffusion? Back diffusion means in the pancreatic duct, we have the cells which have tight junctions. If this tight junctions is disrupted due to alcohol or any other toxins, it causes diffusion of these enzymes into the pancreatic tissue interstitium. When they diffuse into the interstitium, due to the normal pH in the interstitium, they get activated and it causes autodigestion. These are some theories which causes activation of trypsinogen to trypsin due to all these factors. Along with these factors, some drugs like estrogen, corticosteroids, tetracycline are known to cause acute pancreatitis, and the mutations in cationic trypsinogen gene is been associated with pancreatitis. This gene mutation causes the early onset pancreatitis, meaning the pancreatitis in young population. Now we saw there is autodigestion in this condition, acute pancreatitis. The trypsinogen is converted to trypsin. Now, when trypsinogen is converted to trypsin due to these theories and the causes mentioned above, this trypsin activates lipase enzyme, elastase enzyme, lysolecithinase enzyme, phospholipase A2 enzymes. The activation of lipase will cause the digestion of fats. It causes breakdown of fats. Then it causes fat necrosis. Along with that, the saponification of fat takes place. In that reaction, calcium is consumed. So consumption of calcium causes hypocalcemia and tetany in patients with acute pancreatitis. Note that hypercalcemia is one of the cause for pancreatitis, whereas in pancreatitis we see hypocalcemia. Then the activation of elastase by trypsin will act on the elastase of the blood vessels. This will cause destruction of the elastase protein. It will cause pseudo aneurysm and rupture of artery, which can make the patient to bleed till death. Cause hemoperitoneum, the dreaded complication. Then we have lysolecithinase enzyme. This is not the content of pancreas; it's the content of bile. It in the pancreas, it's activated by trypsin. Now, this lysolecithinase will act on cell membrane of the normal resident cells of pancreas, will cause membrane damage. When the membrane is damaged, it obviously leads on to necrosis. When the necrosis is extensive, when the pancreatic necrosis is extensive, it can cause release of myocardial depressant factor by the pancreatic tissue, which will cause cardiac failure. And secondary to cardiac failure, there can be multi-organ failure. And also, once the pancreatic tissue is after necrosis, it can get infected and form infected pancreatic necrosis. Then we have phospholipase A2 enzyme, which is activated by this trypsin. This activated phospholipase A2 will act on the lungs. It will go through hematogenous route, reach the lungs. Thereby, in lungs, it reduces the surfactant, causing ARDS, acute respiratory distress syndrome. Also, phospholipase A2 will cause damage to endothelium of the blood vessels, increases the permeability of the blood vessels in the body, and then it will cause third space loss of fluid, can cause shock, hypovolemic shock. Secondarily, hypovolemic shock can cause AKI, acute kidney injury. Along with these phospholipase causing endothelial damage, increased permeability, and hypovolemic shock, the inflammatory mediators which are secreted when the pancreas undergoes necrosis will cause increased permeability and third space loss. Hypovolemic shock is precipitated by these factors also. So we saw in pancreatitis, these etiologies will cause the activation of trypsinogen to trypsin. The trypsin again activates lipase, elastase, lysolase, and phospholipase A2. This leads to damage of the structures, hypovolemic shock, and pancreatic necrosis, pseudoaneurysm, and saponification, calcium, reduce hypocalcemia, and all. This is about the etiopathophysiology of acute pancreatitis. Now let's see the clinical manifestations seen in acute pancreatitis. What are the symptoms that we see in these patients? These patients characteristically will have sudden onset of severe pain. It will be very agonizing. The severe pain the patient feels in epigastrium, which is radiating to the back of the patient. The pain gradually increases over the hours. It becomes more and more severe as the time proceeds. The pain is partially relieved by bending forward and stooping. It's called as Prayer's sign. Then, associated with pain, the patient will have vomiting, which is frequent and effortless. Why vomiting? Because when there is inflammation of pancreatic tissue, it causes reflex pylorospasm. So reflex pylorospasm will cause vomiting, effortless vomiting. The patient can have hematemesis and melena due to necrosis of duodenum. It suggests it has worst prognosis. It suggests the bad disease and severe disease. The patient can have low-grade fever due to release of inflammatory mediators, secondary to pancreatitis, necrosis, and all. Now, these are the symptoms with which the patient can present. What are the signs that we see on clinical examination? On general physical examination, we see cyanosis due to ARDS, cardiac depression, and all. We can see mild jaundice, which is secondary to edema of head of pancreas, leading to the cholestasis because bile duct pass through it. Then we have shock features. Patient can have features of shock, which is tachycardia, feeble pulse, and hypotension. The reasons for shock we already discussed. The systemic findings are on GIT examination. The patient will have guarding and rigidity in the upper abdominal region, along with tenderness in the epigastrium. And then the patient will have abdominal distension. Abdominal distension can be secondary to paralytic ileus, which is caused due to pancreatitis or due to blood and fluid accumulation in the peritoneum. Then we have other signs due to hemorrhage in the peripancreatic and retroperitoneal space. Then the hemorrhage, the blood will seep through the facial plane, causing various signs. Those are Cullen sign, Gray Turner sign, and Fox sign. Cullen sign is bluish ecchymotic lesion seen around the umbilicus. This is Cullen sign. Gray Turner sign is bluish discoloration in the flanks. Fox sign is bluish discoloration in the inguinal region due to hemorrhage. Then we have on examination of respiratory system, we can see tachypnea, crepitations, and bronchi due to ARDS, that is acute respiratory distress syndrome. These are about the clinical manifestations that we see in acute pancreatitis. Now, what are the complications that is associated with this condition, acute pancreatitis? Systemic complications are hypocalcemia due to saponification. The patient can have tetany due to this hypocalcemia. Then we have disseminated intravascular coagulation due to endothelial damage. It can form microclots. The widespread microclots formation in the body can lead on to consumptive coagulopathy. The patient can bleed. The markers of disseminated intravascular coagulation are the platelet count less than 1 lakh per millimeter cube, fibrinogen less than 1 gram per liter, fibrin split products more than 18 microgram per deciliter. The local complications are word of necrosis. When the necrosis of the pancreas is severe, it causes word of necrosis or pancreatic necrosis. The pseudocyst, pancreatic pseudocyst, due to the collection of inflammatory fluid around the pancreas and its organization by fibrosis causes formation of pseudocyst. Then we have pseudoaneurysm of the splenic artery. Secondary to pancreatitis, the patient can later bleed and it may cause death of the patient. The pancreatitis can cause the thrombosis of splenic vein, which can secondarily cause portal hypertension. These are all the complications the local and systemic complications of pancreatitis. Now, how to manage these conditions? Coming to investigations, when we do CBC, complete blood count, the hemoglobin of the patient will be reduced. When we do RFT, we should do RFT, that is renal function test, to rule out acute renal failure. The enzymes level estimation is very important. The serum amylase level will be more than 1000 Somogi unit per, or it will be rising titer of serum amylase. The serum amylase rises during first 24 to 48 hours. Then it reduces to normal level within 3 to 4 days. Then we have other marker, enzyme marker, that is serum lipase, which is more specific compared to serum amylase, but and also it persists for longer period compared to 3 to 4 days of serum amylase, but it is very difficult to measure this serum amylase. So usually the serum lipase, usually the serum amylase levels are estimated in clinical practice. Then we have radiological examination, that is X-ray. On X-ray, we can see gas in the abdomen, and due to paralytic ileus, we can see colon cutoff sign, that is dilated colonic loop and incomplete ostrations. We can see sentinel loop, that is focal dilated proximal jejunum on X-ray. CCT, contrast enhanced CT, is the investigation of choice. It should be done after 72 hours after of the attack of acute pancreatitis, because doing it after 72 hours help us to look out for, help us to grade the severity of the disease accurately. Then we have the Ranson's criteria for classifying pancreatitis as acute severe pancreatitis. The Ranson's criteria, it has two types, that is non-gallstone pancreatitis and gallstone pancreatitis. For the gallstones pancreatitis is different. I am discussing non-gallstone pancreatitis because alcohol intake is the most common cause of pancreatitis in our country. And the Ranson's criteria says that if any of the 3 or more criteria in these following conditions is met, it suggests acute severe pancreatitis. At admission, if the patient is more than 55 years, on investigation, if the patient glucose is more than 200 mg per dl, AST or LDH level is more than 250 international per unit, or LDH more than 350 international per unit, due to cholestasis and cholestasis, we saw there can be impaired liver function. So, or WBC count more than 16,000 per millimeter cube, any of the 3 of these components is present, it suggests acute severe pancreatitis. Or within 48 hours of admission, if the patient fluid needs is more than 6 liter, or on investigation the hematocrit is decreasing by more than 10%, or blood urea nitrogen increases by more than 5 milligram per deciliter, serum calcium level less than 8 mg per dl, and arterial PO2, partial pressure of O2, less than 60 mmHg, or base deficit more than 4 milliequivalent per liter, any of the 3 component is present, it suggests acute severe pancreatitis. These are all the investigation findings and one of the prognostic marker that I told. Then we have treatment of this condition, pancreatitis. Most of it is managed conservatively. In 5 to 10% of patients, we perform surgery. The conservative treatment is nil. Patient should be kept on nil per oral. We give IV fluids, ringer lactate at the rate of 250-400 ml per hour, and simultaneously we should do urinary catheterization. So we should maintain the urine output of the patient till up to 50 ml per hour. Then we should give analgesia to the patient by, we can give pethidine or other drugs for analgesia. If the patient has hypoglycemia, we should give 10 ml of 10% calcium gluconate. Then in order to reduce the pancreatic secretions, we can give octreotide and somatostatin to the patient. To reduce the complications like stress reversal, we can give IV ranitidine to the patient at the rate of 5 mg every 6th hour. And also we can give IV antibiotics to the patient if the patient has severe pancreatitis or infected necrosis. We can give meropenem. The nutrition to the patient is, initially we give total parenteral nutrition. After the paralytic ileus subsides, we'll start enteric feeding as soon as possible, that is by nasojejunal tube. Then we have surgery. Surgery is only indicated when the patient has severe necrotizing pancreatitis or pancreatic infected necrosis, or if on conservative treatment the patient is not improving, is going on deteriorating, we'll perform surgery. That is pancreatic necrosectomy, where we preserve the viable pancreatic parenchyma and the intra and extra parenchymal necrotic material is removed, the pancreatic fluid is removed, and the toxins around it is removed. This is pancreatic necrosectomy. For the patients who has gallstone pancreatitis, we'll perform endoscopic sphincterotomy initially. Then after 2 to 3 weeks, we can perform cholecystectomy. This is about acute pancreatitis. To summarize, acute pancreatitis is a non-bacterial inflammation of pancreas caused due to activation of pancreatic enzymes leading to autodigestion. The patient presents with acute abdominal pain. Etiological factors is broadly divided into the factors which cause pancreatic injury and duct obstruction. The factors causing duct obstruction are alcohol, gallstones, duodenal ulcer, carcinoma, periampullary carcinoma, hyperparathyroidism, and then hyperlipidemia, hypercalcemia, sphincterotomy, cannulation of CBD, basketing of stones. Then we have the factors causing pancreatic injury, ischemia due to hypothermia, hypotension, scorpion sting, and autoimmune attack due to polyarteritis nodosa, Coxsackie, mumps infection. They have which have tropism for acinar cells of pancreas. Pathophysiology, we have autodigestion of pancreatic tissue due to activation of trypsinogen to trypsin and secondary activation of other enzymes. The postulated theories are stasis due to obstruction, duodenal reflex, and back diffusion. The activation of trypsin will cause activation of lipase, elastase, lysolipidase, and phospholipase A2, causing fat necrosis, hypocalcemia, and then pseudoaneurysm, and then lysoiodinase causing necrosis, extensive, if it's extensive, cause release of myocardial depressant factor and cardiac failure, phospholipase A2 causing endothelial damage, increased permeability, hypovolemic shock, and ARDS. Then we have clinical manifestation symptoms with which the patient presents is sudden onset of severe pain in the epigastrium, radiating to back, increasing, gradually increasing, relieved on bending forward or stooping, causes prayer sign. The patient can have frequent effortless vomiting, hematemesis, low-grade fever. The signs are on general physical examination, patient can have cyanosis, mild jaundice, shock. On systemic examination, GIT, the patient will have guarding rigidity in the upper abdomen and tenderness in the epigastrium region, abdominal distension, Cullen sign, greater sign, Fox sign. And then on RS examination, the patient will have rhonchi crepitations, tachypnea due to ARDS. Under management, we have investigation, CBC, HB will be reduced, we should do RFC, enzyme level, serum amylase, and lipase will be raised. The patient can have hypocalcemia. On X-ray, we have gas in the abdomen, gas inside the bowel loops, colon cutoff sign, sentinel loop sign. CECD is the investigation of the sign done after 72 hours of the attack of pancreatitis. We have Ranson's criteria. If more than or equal to 3 of these criteria is increased, then it suggests acute severe pancreatitis. Then we have treatment of this condition. Conservative treatment by the patient is kept on limp-oral, IV fluids are given, analgesia with pethidine, IV antibiotics like meropenem, and then IV ranitidine is given. If the patient has hypocalcemia, 10 ml, 10% calcium gluconate is given. Nutrition initially TPN followed by enteral feeding. The surgery is only performed in severe necrotizing pancreatitis, pancreatic infected necrosis, or if the patient deteriorates on giving even after giving conservative management. The surgery is pancreatic necrosectomy, where the intra and extra pancreatic necrotic material is removed along with pancreatic fluid and toxins by preserving the viable pancreatic tissue. In gallstone pancreatitis, initially we perform endoscopic sphincterotomy followed by cholecystectomy after 2 to 3 weeks. Thank you for listening.